Most people think sleep apnea looks like one thing: a heavy snorer, someone whose partner has been banished to the spare room, someone who wakes themselves up with a sound like a blocked drain. That picture is real. It is also incomplete in a way that has left millions of people undiagnosed, because sleep apnea has a sign that appears during the day, in a person who may not snore at all, that has nothing to do with the airway at night. It shows up as a headache, every morning, gone by mid-morning, back the next day. Morning headache is so common that most people who have it have stopped registering it as a symptom. It has become part of the routine. Wake up, head throbs, drink water or coffee, wait for it to pass. They attribute it to dehydration, to sleeping in the wrong position, to stress, to too much screen time the night before. The headache resolves quickly enough that it does not feel serious. It returns consistently enough that it has become background noise. What most people do not know is that a headache that is present on waking and resolves within 30 to 60 minutes. To understand why, you need to understand what is happening in the airway during an apneic event. In obstructive sleep apnea, the muscles of the throat relax during sleep to the point where the airway partially or fully collapses. Breathing stops for 10 seconds, 30 seconds, sometimes longer. This is an apneic event. In moderate to severe sleep apnea, these events occur dozens of times per hour throughout the night. The person may never fully wake. They may have no memory of anything disrupting their sleep. But each time the airway collapses and breathing stops, oxygen levels in the blood fall and carbon dioxide levels rise. Carbon dioxide is a potent vasodilator. It causes blood vessels to widen. When CO2 accumulates in the blood during an apneic event, the headache is not from the pillow. It is not from dehydration. It is the brain recovering from a night of repeated oxygen deprivation and vascular disruption that the person slept through entirely. Morning headache is the sign that reaches furthest outside the bedroom, but it is not the only daytime sign of sleep apnea that has nothing to do with snoring. Waking to urinate at night, nocturia, is one of the least recognized signs of sleep apnea, and the mechanism surprises most people who hear it for the first time. When the airway collapses and the body struggles to breathe against the obstruction, negative pressure builds in the chest. The heart detects this pressure change and misinterprets it as a signal that the body is volume overloaded, carrying too much fluid. In response, the heart releases a hormone called atrial natriuretic peptide, which signals the kidneys to produce more urine to reduce the perceived fluid excess. The kidneys comply. The person wakes to urinate, not because their bladder is unusually full, not because they drank too much before bed, but because their own struggling airway triggered a hormonal chain reaction that produced urine they did not need to produce. A person waking 2 or 3 times a night to urinate, without a urological explanation, without excessive evening fluid intake, without a prostate condition or bladder issue, is frequently a person with undiagnosed sleep apnea. This connection is almost never made because the symptom points toward the bladder, and no one asks about the airway. Urology appointments are booked. Sleep studies are not. Waking with a dry mouth is another sign, and like morning headache, it is attributed to almost everything before sleep apnea is considered. The dry mouth of sleep apnea is produced by mouth breathing during sleep. The airway is partially obstructed, nasal breathing becomes insufficient, the mouth opens to compensate. But the dryness is often severe enough to wake the person and significant enough that no amount of water fully resolves it until the morning is underway. Lips that crack at the corners. A mouth that feels coated and stale regardless of dental hygiene. A persistent morning thirst that feels different from ordinary overnight dryness. Dry mouth from sleep apnea has a secondary consequence that is rarely discussed. Saliva is the primary defense mechanism against bacterial accumulation in the oral cavity. It neutralizes acid, washes away food particles, and contains antimicrobial compounds that control bacterial populations. When the mouth is dry for hours each night, bacterial growth accelerates, acid is not neutralized, and the teeth and gum tissue are exposed to a damaging environment every night. People with untreated sleep apnea have significantly higher rates of gum disease and dental erosion, and many dentists now screen for sleep apnea specifically because the oral signs are visible before the patient has been formally diagnosed. There is a cardiovascular dimension to sleep apnea that makes the morning headache and the other daytime signs more than inconveniences. Each apneic event triggers a surge of sympathetic nervous system activation, a stress response. The body detects the drop in oxygen and the rise in CO2 as a threat and fires adrenaline. Heart rate increases. Blood pressure spikes. This happens not once or twice, but potentially hundreds of times per night in severe sleep apnea. The cardiovascular system is being stressed during what should be its recovery period. The cumulative result of this nightly sympathetic activation is consistently elevated blood pressure, particularly in the morning, when the overnight surge is at its peak. Resistant hypertension, high blood pressure that does not respond adequately to medication, is strongly associated with sleep apnea. A 2019 study in the European Heart Journal found that sleep apnea was present in 83% of patients with resistant hypertension. Not a minority finding, an overwhelming majority. A person who has been managing blood pressure for years, whose medication has had to be repeatedly increased, whose morning blood pressure readings are consistently higher than afternoon readings, is a person whose sleep should be investigated. The blood pressure may be resistant, not because the medication is insufficient, but because the underlying driver is being missed. The most important daytime sign, the one most directly linked to misdiagnosis and long-term harm, is excessive daytime sleepiness in someone who believes they are getting adequate sleep. Not ordinary tiredness, a heaviness that descends in warm rooms, during meetings, in the passenger seat of a car, sitting quietly after lunch. The kind of sleepiness that requires active effort to fight, and that wins if the environment is even slightly passive. A 2020 study in the Journal of Clinical Sleep Medicine found that people with moderate to severe sleep apnea were 2.5 times more likely to be involved in motor vehicle accidents than those without, because the microsleeps that accompany severe sleep deprivation can occur at the wheel without the driver having any awareness of losing consciousness. The person with this daytime sleepiness does not feel like someone with a sleep disorder. They feel like someone who needs to go to bed earlier, drink more coffee, or manage their schedule better. They have adapted to a baseline level of fatigue so gradually that they have lost the reference point for what normal alertness feels like. They are not lazy. They are running a daily oxygen debt that began the moment they fell asleep the night before. Sleep apnea is diagnosed with a sleep study, either a full polysomnography conducted in a sleep laboratory or a home sleep apnea test, which is now widely available and appropriate for most straightforward diagnostic situations. The test measures oxygen saturation, airflow, respiratory effort, and the frequency of apneic and hypopneic events per hour. That frequency, the apnea-hypopnea index, determines severity. 5 to 15 events per hour is mild. 15 to 30 is moderate. Above 30 is severe. A GP referral is the standard route. But a person who presents with morning headaches, nocturia, dry mouth, resistant hypertension, and excessive daytime sleepiness does not need all 5 of those signs to warrant a sleep study. Any 2 of them, in combination, in someone who does not obviously snore, and therefore has never considered their sleep as the source, is enough to ask the question directly. The question is simple. Have you had a sleep study? If the answer is no, and the signs are present, the next step is asking for one. The partner who snores and stops breathing visibly in the night gets referred. The person who sleeps quietly, wakes with a headache, gets up twice to urinate, has blood pressure that will not respond to medication, and cannot stay awake past 3 p.m. does not, because no one has connected those 4 things to the same cause. They are the same cause. Morning headache, nocturia, dry mouth, resistant hypertension, daytime sleepiness that coffee cannot fix. Sleep apnea does not always announce itself at night. Sometimes it waits until morning, sitting behind the eyes, sending you to the bathroom.